you can see my name is Oyinlola Oyebode, and most people call me Lola, which is here. So to start with, as you could see, I'm going to talk about food environments and inequalities in healthy, sustainable diets. And why am I interested in food and diet? Having spoken to some of you already today, I think you're going to know all of this. But a key reason is because dietary risks are the single main cause of global illness, disability, and death. And 22% of global adult deaths are due to dietary risks. But as well as the impact on population health, producing and distributing the food that we eat also has a huge impact on planetary health. And I really like this graph. Does this shine? Oh, no. Oh, well. So showing 100,000 years ago, the mammalian biomass on planet Earth, and you can see that it's pretty much all wild mammals at that point. And humans did exist then, but we were obviously negligible. But now, wild mammals have been completely decimated and replaced with several times the biomass of humans, and then even more livestock. And so all of this is taking up a huge amount of planetary resources. And as well as that, then we've also got this kind of existential threat of climate change, and a large amount, so a third of greenhouse gas emissions come from the food system. So we can't keep the planet within a safe temperature for human life without addressing these emissions from the food system. But the good thing is that a lot of the things that we would want to do to improve population health from the perspective of diet will also improve planetary health. So one example is the Eat Lancet diet, which is shown here, where thinking about how to feed a population of 10 billion people on planet Earth within planetary boundaries and for everybody to get the nutrients that they require, then the suggestion is that we reduce red meat consumption by 50% and increase fruit, vegetable, and whole grain consumption. And these are things which will improve the individual health as well as improving planetary health. And so reducing that kind of existential threat to human life on Earth. But knowing what is good for us and good for the planet is obviously not enough for people to actually make those changes. There are so many barriers to eating that healthy, sustainable diet. And those barriers are true across the board. But of course, some of those barriers are highest for people who are in the most disadvantaged situations. So just taking the example of price, this is the cost of the Eat Lancet diet as a percentage of daily mean household income. And you can see that depending on where you live in the world, that can be a huge amount of what you're actually earning overall. So obviously that's a huge barrier, but even where these diets are very affordable, people are still not generally following this kind of advice. So there are obviously many, many barriers other than price. So this is why I feel that diet is so important, and that's why mainly in terms of my research, I'm interested in what can be done to support people to eat more sustainably and healthily, and how can that be done in an equitable way. So thinking about interventions that can allow everybody to eat better and not just the people who've got the greatest agency and the greatest ability to make those changes. So now I'm actually going to go back and tell you a little bit about how I actually became interested in diet in the first place. This is a little bit autobiographical because, as Hannah said, I've got these 3 different themes to my work, and it can seem like a bit of a patchwork, but if I tell you in an autobiographical way, hopefully you see how they make sense together. So I'll tell you a bit about how I became interested in diet, and then how I became interested in very deprived urban neighbourhoods. And then I'll talk about some work that I've done on diet in very deprived urban neighbourhoods. And then I'm going to change direction and tell you about a very big UK funded project called Salient, and then a bit about future plans. So starting with how I became interested in diet. I trained in public health. So in the UK, to train in public health, you spend time rotating around different organisations in the public health system, ticking off competencies. So for example, this includes NHS organisations, local authorities, national organisations as well. I spent some time in NICE, which is the body that makes decisions about funding, treatment. And I also had the opportunity to do an academic placement during that training. So you tick off competencies to show that you have certain skills, you sit exams, and at the end of that, you get a certificate of completion of training, which means you can act as a public health consultant in the public health system. But for my academic placement, I went to UCL and I worked with the team who run the Health Survey for England. The Health Survey for England has been running since 1991. It's annual data, and every year up to 10,000 adults and 2,000 children are surveyed. And the survey includes self-reported measures, but also examination measures. So as well as an interview, people have their height measured, their weight measured, their blood pressure done, and spit and blood and urine are collected to get some biochemical measures. And most importantly for the study I'm about to show you, this data is linked to mortality data. So when the person's interviewed, they're asked, do we have permission to link to your health service data? There's the mortality data. And so if people say yes, then it's linked. I said in theory because it's actually not been updated for the last 5 years, but at the time it was up to date, and hopefully it will be updated again. And all of this data is available actually in the UK data archive, so anybody could use that if there was something that was of interest to you. But my main project, it's gone off the bottom. The main project that I went to UCL to do was to look at how the Health Survey for England was used in government policy making and monitoring. And I found out that it was absolutely critical to policy making and monitoring, because this is how the UK government knows what's going on with the health status of the population. Unlike things like healthcare records, which rely on people consulting, this tells you about the actual health status of the population because it's collected from people who aren't seeking care. So you can also look at undiagnosed disease, like undiagnosed hypertension. So that was my main project. But while I was there, Jenny, who supervised me, who's this person here, she said, would I be interested in looking at fruit and vegetable consumption that's reported in the Health Survey for England and mortality? And mainly because I like eating fruit and vegetables, I thought, oh, yes, that's a good idea. So I did that analysis. So I was looking at the association between fruit and vegetable consumption and all-cause cancer and CVD mortality. And for that, I looked at, 65,000 participants. So from a lot of survey years, we brought all of those survey years together, and they were the participants aged 35 plus. So they'd completed the survey between 2001 and 2008, and we followed them up to see if they died up to and including 2013. And used information from the question when they were asked their fruit and vegetable consumption in the 24 hours before the survey. And I just thought I would show you the raw plot. So here is a survival plot at the start, at time 0, when the people were asked the question, 100% of them were alive. This yellow line is the line of people who ate 7 or more portions of fruit and vegetables the day before the survey. And so you can see that by the end of the follow-up, about 95% of them were alive. And then for all of the other groups, you can see that for the people who ate 5 to 7 portions of fruit and vegetables the day before the survey, more of them had died by the end of the follow-up. For the people who had eaten 3 to 5 portions, then the green line is 1 to 3 portions, and then that blue line is the people who'd eaten less than 1 portion of fruit and vegetables the day before the survey. And by the end of follow-up, about 90% of them were alive. And that's just the raw data, but I did analysis adjusting for demographics and also some other behaviours. And we also excluded everybody who died within a year of the survey being done, because we thought there might be some reverse causality. And we did still see this effect, that the more portions of fruit and vegetables people had consumed the day before the survey, the lower the risk of dying during the follow-up. And bizarrely, probably because, well, so this was published, and it was published on it was published in, March 2014. And somebody wrote an editorial alongside it. This is a person called Simon Capewell, and he's quite a big name in the UK. And he wrote this editorial saying that we should update the 5-a-day message, which says that you should eat 5 portions of fruit and vegetables a day, and we should now say 10, we should eat 10 portions of fruit and vegetables a day. And I think it was also a very slow news day, because that meant that we were front page news across pretty much every paper the following day, which was a big surprise. And I also had to do about 21 radio and TV interviews in the next 24 hours. And here I am on BBC Breakfast, where very embarrassingly, the earpiece fell out of my ear and I couldn't hear what they were saying. So it was awful. But in response to that, I got I think a picture's missing somehow. So in response to this, I had a huge amount of email and letters coming in, because I think there had just been so much exposure of this paper. I actually had 30 letters written to me by a class of children aged 10. And I had some letters from some people in prison for murder. And I also had some letters from people who made smoothies, and they all had things that they wanted to tell me about my research. And really what I concluded after this was, well, we actually already knew before my paper that consuming more fruit and vegetables are better for human health. That was really well known. But what people were saying to me was, but how can we? It costs too much, or it's impossible to find. Or they had all sorts of reasons why this was so difficult, or suggestions of how actually, if don't just tell us this, we need help to do it. And I thought, I don't really want to do any more epidemiology on this question at all. But what I'm interested in knowing is, how can we really support people to consume more, because they find it very hard. So here is my introduction to why I was interested in food and diet. And from that point onwards, I kept up kind of an interest in food and diet and obesity, and kept doing projects along those lines. But when I finished my public health training, I then looked for a job, and I decided to come into an academic job. So I got a job as an associate professor of public health at University of Warwick. And I'll tell you now about how I became interested in very deprived urban neighbourhoods. So in the UK at the time, this was about 2014, there was a need to reduce government spending. And the way that that was done was by overlapping the overseas development aid budget with the research funding budget. So neither of those budgets was reduced, but those budgets were overlapped. And what that did was create a certain pot of money that was specifically for research into global challenges, that was going to be in low middle income countries, and would support the aid objectives, and also be spending money in universities and with researchers. And so because of this, University of Warwick responded to that by setting up Warwick Centre for Global Health. So they core-funded 3 posts, and one of those was mine, and there was a professor, and I had one other colleague, so 3 of us all together. And they set us up in order to respond to the fact that this government funding was coming. It was specifically for work in low middle income countries, and they wanted us to be able to take those opportunities. So this is University of Warwick, very nice blue sky there. So this was actually a very difficult task, because this was 3 people who'd never done work in the middle income countries suddenly coming together and being told, write these grants, win this money to go and do research here. And the way that we kind of started to get off the ground was mainly because University of Warwick already had some really nice links, and those links were mainly through Carter, which is a programme that supports African PhD students to do their PhDs in African institutions. And so there are a lot of African institutions who are part of that consortium, but there are also a few northern partners, in University of Warwick as one. So that means that we would go and take part in kind of week-long seminar series for those PhD students. So one of the organisations in Carter was APHRC, the African Population and Health Research Centre. And so it was through our involvement in Carter that we got to know APHRC. And one of the things that APHRC does is that it has the Nairobi Urban Health and Demographic Surveillance Site. So a very unique data set, because this is an urban data set that started in the early 2000s and has, again, collected data on this population every year since then. So it's a really very unique data set, because of the other health and demographic surveillance sites, they're all in rural areas, and this one was urban. And these are actually, the surveillance site includes 2 slums, so Viwandani and Korogocho, both in Nairobi. And because of that surveillance site, APHRC they have the world-leading expertise in terms of slum health, because of having these really good relationships with the communities there, and having collected data and advocated for their health over the years. So my boss was Richard Lilford up here, and he spoke to Alex Easy, who at the time ran APHRC, and he said to him, would you like to write a Lancet series on slum health? If you would, then we'll write it, but if you can review it, check it, send us sources, it would be just good to have you as kind of the backbone of the piece. And Alex said yes, and Richard wrote to Bill Summerskill at the Lancet and said, you really need a Lancet series on slum health? And Bill Summerskill said, yes, okay, I agree. So then we wrote it, and that was published at the end of 2016. And so this is really where I think suddenly we had this good relationship that we built up through this existing consortium, and were able to kind of finally find something that we could do that was useful. And the main contributions, some contributions that I'd highlight from this series were that we kind of redefined slum. So we talked a bit about the use of the word slum, the fact that the people who live in slums themselves do use this word. So there's a large grassroots organisation, Slum and Slack Dwellers International, SDI, and also the UN uses the word slum, and there's no perfect synonym. So people talk about informal settlements, but not all slums are informal. So that was one thing that we did, talk about using the word slum. And then we also defined slum as being something that is a geographical area, a neighbourhood. So there are lots of UN agencies that do use this kind of neighbourhood definition, but there are others, actually UN Habitat, where they can talk about a slum household as a household that lacks this, that, and the other, when actually we said that isn't a slum, that is talking about poverty, and slums are separate from poverty. You actually have some people who are rich who live in slums, and obviously there are some people who are poor who don't live in slums. And so we're kind of distinguishing those things, because the fact is that if you live in a slum, no matter if you've got a toilet, if nobody in your neighbourhood has one, then you're still exposed in the environment to those same things. So we're kind of explaining, defining slum health that way. Then we also talked about the fact that 1 billion people are estimated to live in slums, and yet they're very, very underrepresented in research, which is for a lot of practical reasons. I mean, often they're not included in the census if they're informal. And if you're not included in the census, you might not be in sampling frames for any other studies. There's also, sometimes people feel that they are not safe to go into slums. There are lots of reasons why this might be, but it's still the case that some populations are very underrepresented in research, but also the types of research. So the types of research that have been done in slums that tended to focus on maternal and infant health and on infectious diseases. And there's very, very little about non-communicable diseases. And then finally, talking about the fact that because the definition is the neighbourhood, environmental interventions could improve the lives of many people simultaneously. So actually that is a benefit over trying to fight poverty spread out. You could think about interventions that can be done in the food environment, for example, or in the environment in another way, and it could improve the lives of many people because of the overcrowded nature of slums. So probably largely having written that Lancet series, we then got money from the NIHR, £5 million over 4 years to do work in slums in Bangladesh, Pakistan, Nigeria, and Kenya. And this was aligned to the person who was my line manager, Richard Ilford's interests. So we were looking mainly at health service use. And we did 5 work packages. We did geospatial mapping, so looked at the health services that were provided in slums, looking at so mapping where all of them were and also characterising the types. Then there was the household survey, which is what I was responsible for. So I led work package 2. So we did household survey with about 1,000 households in each of the sites. Then there was an evidence synthesis work package. There was some health economics. And finally, there was the engaging stakeholders, which included qualitative work and community engagement. Oh, there we go. Yeah. And yes, so, again, mainly because kind of following on from that expertise, I've been involved in other studies, including one on sexual and reproductive health and rights in adolescent girls and young women in slums in Uganda, and then one that was looking at climate-related health risks in slums across Africa. And then also this one was in slums across Africa, which was looking at the response and recovery to COVID-19 in informal settlements in 7 African countries in partnership with SDI. So as you can see, I've kind of ended up with these 2 threads of research going on. So, particularly as I've described how the Warwick Centre for Global Health was set up during that time when we were finding our feet, so between 2014 and the publication of the Lancet series, I was doing a lot of work that was funded by the local authorities sometimes, that was about diet and obesity. But I started to try to bring these things together and look at diet in very deprived urban neighbourhoods. And I'll tell you something about those projects. And mainly I did this under the umbrella of that big NIHR project. Although that was focused on health service use, I kind of carved out my own projects looking at diet and diet-related ill health. So this was a systematic review led by Ola Uthman. There's the reference up there. And we were looking at any primary studies that had collected data on either prevalence of type 2 diabetes or hypertension, so diet-related ill health in slums. And we found a number of studies, and the reason why I've shown this graph is that we found a range of estimates of the prevalence of these up to 52.5% for hypertension, up to 25% for type 2 diabetes, so quite high prevalence of these illnesses. This is important because actually I think there's a feeling that because people who live in slums are financially poor, that you can't afford cigarettes, you can't afford to eat too much, you can't afford to do all of these things that might cause NCDs, non-communicable diseases. And so people think, oh, they're not such a big deal. And you know that so much of the research has been on maternal and infant health and on infectious disease, and so it's really just invisible. But there are all these assumptions that these illnesses aren't a big deal here. Those people are lean, they're physically active, they're walking everywhere, they don't have enough to eat, so they're slim. And actually, maybe that's not the case. But the other thing is that what Ola did is, where he found more than one study from the same country, he plotted them on this graph. So, for example, there were 4 studies from Bangladesh, 4 from Brazil, 22 from India, 8 from Kenya, 4 from Nigeria. And this is like, for example, in purple, all of the Indian studies were plotted, and he drew a line through them. And so not just that we can see that on occasion there is high prevalence of hypertension and diabetes, but that generally it seems as if these things are increasing. So it seems like this is going to be a growing problem. And yes, so then the other thing that I did still within that NIHR unit was that I did some secondary analysis of data from that Nairobi health and demographic surveillance site. So there was some data that at the time was 10 years old that had been collected on various different behavioural risk factors and also some of the biomarkers of CVD risk. And we used a WHO risk prediction where you put in some of those, so you put in people's height, weight, put in their cholesterol if they've got it, put in their blood pressure if they've got it, and use that to calculate their risk over the next 10 years of having a cardiovascular event. And what we found was that most of the study participants at that point had a low risk, so 94.5% of people had risk of less than 10% of a cardiovascular event over the next 10 years. But actually, the reason for that was mainly age. So, of course, being young reduces your risk of those things. When we started looking at some of the risk-enhancing factors, so the WHO risk prediction has a lot of standard things that you put in, but then it says, however, we may underestimate the risk if your waist circumference is bigger than something or other. So even though you don't put the waist circumference in, if you can see that the obesity is generally abdominal obesity, then it may be that the risk is higher in this population. And when we looked at those risk-enhancing factors, we found that actually many, many more people went into higher risk groups. So again, this is quite worrying, because it seems like even though right now there might be generally low risk, you can see that this risk is likely to increase. These people are young, but actually, and you might think, oh, there's not so many people who are overweight, but the pattern of overweight seems to be a pattern that is probably going to increase risk of CVD in the future. Oh yeah, this is the public health registrar who did that secondary analysis with her poster. And then, sorry, this isn't a very beautiful slide, but also with that NIHR, so the household survey that I did was mainly looking at health service use in line with the main objectives of that unit, but we included the DHS socioeconomic module, and I just started using that to look a little, see what I could explore. And one of the questions in that is, do you have a separate kitchen? And you can see, in terms of the people who said yes, far along that row, that less than half of the households had a separate kitchen. And this is straight away, if you're thinking about food and diet in these neighbourhoods, then you know that those people aren't cooking for themselves. They're usually buying ready-to-eat food on the street, and that's like the main source of food. So it just starts to give you an idea of where the kind of places to intervene might be. Then you can see even fewer people say yes to owning a refrigerator, and actually we know that because of the electricity not being so reliable, even those people who have a refrigerator can't necessarily reliably use it. And then finally, there is a question on household food insecurity. And again, you can see it's really high, 40% of households saying that they experienced food insecurity. And food insecurity is often in line with a lot of the things that the poor diet that causes non-communicable diseases, because if you're hungry, then when you have the chance to eat, you buy high calorie, high fat, high salt, high sugar food, which is obviously not good for your cardiometabolic health. And so, yeah, looking further into the food insecurity, I had a master's student who looked at the households that had food insecurity and the data that we had, and she found a lot of things that you'd probably expect, like the head of the household's educational status and the wealth quintile. You could see generally that wealth is protective in terms of food insecurity. But one finding that I thought was very interesting was that households were asked, do you own agricultural land? And in the Nigerian sites, then there's no effect of owning agricultural land on the odds of being food insecure. But in one of the Kenyan sites, the Pakistan site and the Bangladesh site, you can see that they had a lower risk of food insecurity if the household owned agricultural land. But then the other Kenyan site, if they owned agricultural land, they had an increased risk of food insecurity. So I really think that that is a very interesting thing to explore further, because if you are producing your own food on your own agricultural land, it's possible that if there was bad weather, for example, that actually puts you in a worse position. Although you generally think it's a protective factor, it's obviously not always a protective factor. And then we had some underspend in the NIHR budget, and I was very happy to find that Romena Iqbal, she was the Pakistan PI, but she's actually a nutritionist by background. So we met through the NIHR unit that we had, but we developed a relationship and realized that we had many common interests. So when we had an underspend, we asked the NIHR, can we use it to do some work on the food environment? And they said yes, which was great. So we actually also mapped all the food vendors in our Pakistan site, and we categorized them. So we saw where the general stores are, the kiosks, etc. We did some qualitative work with the food vendors, learning a bit more about how they learned to cook, and also about why they chose the particular products that they chose, and any interest that they had in selling healthier products. And then we collected 34 ready-to-eat foods that people said were the most popular. And we found that 32 of those contained trans fats, which the WHO says we should eliminate from food supplies. And we also found that 21 of them had more than 20% of the daily fat limit, and 12 had more than 20% of the daily salt limit. So we found that the food that was on offer in those slums is not very healthy. And that is what people are eating day in and day out. Finally, I was just going to show you this, I still have time, yep. I was just going to show you this systematic review that was looking at the influence of the food environment on diet, nutrition and health outcomes in urban, lower middle income countries. So this study was because I was interested in knowing what do we know about which aspects of the food environment are linked to diet, nutrition and health. And we did this study, found 74 unique studies that we included in our synthesis. And you can see that most of those are, in fact, from Brazil. And then that we only found 7 interventional studies. So most of these were observational studies where they, for example, mapped the availability of supermarkets and correlated that with diet or obesity levels, for example. And we only found 7 interventional studies that actually tested an intervention. They were all from middle income countries: Iran, Mexico, Brazil, South Africa and Thailand. So there's a huge amount of work here to do to understand what interventions could be useful in these areas. So we mapped whatever the studies had done to this framework of the food environment. So looking at these domains: availability, prices, vendor and product properties, marketing and regulation, accessibility, affordability, convenience, and desirability. And most of the evidence was for availability. So in green, availability, it's telling us that in the neighbourhood level, we had dense and consistent evidence that availability of food is related to diet, health and nutrition outcomes. And similarly, accessibility metrics, we had dense and consistent diet evidence. And then for affordability, convenience and desirability, we had sparse evidence, but it was very consistent, suggesting that affordability is related to diet, nutrition and health, that convenience and desirability are also. So that is something to pursue. So in conclusion from this work, it seems that diet-related chronic diseases are substantial and that they're growing in these neighbourhoods, and that is driven by an unhealthy food environment. But there's very little research currently on how to intervene to improve that. So now I will change tack completely to tell you about a different project that's in the UK. And when I tell you about my future plans, you'll see why. So this is Salient. So all of that information at the very beginning when I was talking about food and diet on the global scale, we've got the same problems locally in the UK. So obesity trends continue to go up, huge amount of illness, disability and death related to our poor diets in the UK. And then this diagram over here is looking at land use, and what you can see, actually, can I point this way? No, I can't. Yes, so so much of our land is spent on livestock farming. And then when you look at overseas land that used to be the UK, a huge amount again on livestock farming, where we've got poultry and pigs over here too. And the UK has responded by having a series of different commitments to, first of all, apparently we're going to try and protect more land for nature. And then, of course, we want to try and reach net zero. And we've had huge numbers of successive policies to try and tackle obesity. So diet and the food system are priorities for the UK government right now. And the National Food Strategy says that they want to increase by 30% fruit and vegetable consumption in the UK population, reduce by 25% food high in fat, salt and sugar, and reduce by 30% meat consumption. So the UK government put out a call for food systems trials to encourage healthy, sustainable diets, to help the UK government to know what policy decisions to make to help us meet those policy objectives. And this was in 2 stages. So there was 6 months of co-design where the group of researchers that were awarded the money were given the chance to work with food system partners and the UK government to think about what the trials might be, what interventions we might test. And the consortium of researchers that won the money included me at Queen Mary. It's led by Peter Scarborough in Oxford and Martin White in Cambridge. And then there are people from these other organisations here. So yeah, there was a consortium of researchers, the public, the programme board, which includes DEFRA, which is the Department for Environmental, Farming, Rural Affairs, FSA, which is the Food Standards Agency, DHSC is Department for Health and Social Care, DFE is the Department for Education, and the Cabinet Office. So all of these departments came together, and food systems partners. And once we'd prioritised some interventions, then we had to deliver them and evaluate them. And this is happening in 2 tranches, each of 5 trials. So in tranche 1, we have got these trials. We've got a trial with Co-op, which is a large grocery store chain, and they are looking at increasing their plant-based food offer in the shops in a randomised fashion. Then we've got Community Shop, which is a community sector. So it's for people who are experiencing food insecurity. They can go and spend a certain amount of money in the community shop. And so Community Shop are looking at different promotions of healthy food. Then we have Cook. They sell ready-made frozen ready meals. So it's like a shop that just has a lot of freezers in it, and you can go and buy food that you just put in your oven at home. And they have also tried to look at increasing the availability of plant-based food to see whether that increases purchasing of plant-based food. And then we've got a trial with Compass. Compass do catering for workplaces, and they have looked at price and availability of plant-based food in workplace canteens. And then I'll tell you a bit more about trial 5, which is the one that I'm co-leading with an economist at University of Warwick called Thijs van Rens, which is the sustained trial. So our trial is looking at online grocery shopping. There we go, which is a small market share in the UK currently, but it's growing. It grew a lot in the pandemic, and it's still growing a little bit now. There's very limited literature on how to intervene in the online grocery shopping, and most of the literature that does exist has used virtual supermarkets, so they're not real supermarkets where people do their real shopping and take their real shopping home. But we are intervening in a real supermarket webpage using a browser extension, a plugin. So our participants download the plugin. The plugin manipulates the way that the website appears when they do their online shopping on the online grocery shop. And this is exciting because, yes, we're trialing 2 different interventions, which I'll tell you about in a second in this particular trial. But what's very exciting about this is that it has given us a platform for evaluating so many interventions, because unlike the people who are working in Co-op, where you have to say, OK, Co-op, we want you to rearrange your shelves like this, and then somebody has to go and physically do that. And then, first of all, they have to physically do that, but also in terms of randomizing, of course, it's quite difficult to randomize on an individual basis. So you have to have enough shops and the neighborhoods might vary. In this case, we can randomize our participants and our participants see the interventions we want them to see. We get all of the data on their clicks, all of the data on their purchasing. So we can very quickly and cheaply now implement various interventions in this online grocery shop. And so the two interventions that we're trying eco labels. So when people are browsing on the supermarket website, they see something like this, if they're in the intervention group, which gives them a rating, the eco score of the product that they're buying, which is rated across 16 different impact categories, and it's per kilogram for each product. And this is of interest. We don't think that this is going to be very effective, and I'll show you the preliminary results in a minute, but this is something that the UK government's really thinking about. And in France, they've already implemented eco labels on clothes, and eco labels on food are coming in soon. So it's really good to get some evidence about how this changes behaviour. And then the other thing that we're doing is that when people check out, they have a pop-up which says, there's a more sustainable alternative to something in your basket, and they can have that for up to 3 things in their basket. So everybody gets that pop-up, but then the groups are randomised to either have just that pop-up, they have that pop-up and they have a 50p discount on the alternative, or they get a £1 discount on that alternative. And yet the swaps are more sustainable, no less healthy, and at most £2 more expensive. Well, these participants have been recruited from an online survey company since April 2024 in 5 waves. They're people who say that they usually shop online on the grocery shop that we are working on. And if they're eligible, then they install the plugin, and then they're randomised to 1-to-1 to eco labels, or 1 in 3 groups for the discounts. And they're asked, please do your normal online grocery shopping for the next 8 weeks. And after 8 weeks, they get an end-line survey that says things like, did you notice the eco labels? Did they change your behaviour? Although we know if they really changed their behaviour because we have their shopping data. And this is where we are so far. So here's April, our first wave. Here's our second wave. And we've got, and so we're still in the middle of data collection. These 2 waves are finished, but these 3 waves are ongoing. But just to tell you our preliminary findings, based on waves 1 and 2 and partial data from waves 3 to 5, we've got 1,396 people who've completed at least 1 shop so far. And what we see is that eco labels have pretty much no effect at all on the sustainability of purchases. So a lower number is more sustainable. So there is a minus there, but it's tiny and not at all significant. However, price discounts are improving the sustainability of purchases if they're sufficiently large. So for the £1 discount, we can already see a significant difference between the £1 discount and the people who don't get any discount. And the 50p is approaching there. Hopefully we'll see something when we've got a bit more data. And then finally, there seems, because we've done this in a factorial design, so people are randomised to the eco labels or not, and they're randomised to the discounts in 3 groups. So we can look at the interaction between the interventions, and it looks like there is one. So for the price discounts with labels, we can see a significant effect. And for the price discounts without the labels, we don't. So it looks like the price discounts are working better when people can also see the eco scores of the products that we're offering. So by March, we'll have finished data collection, and then we'll have our actual results. But I suppose just in terms of future plans, I am now at Queen Mary. So I moved from Warwick to Queen Mary in September 2022, and I now lead the Centre for Public Health and Policy at Queen Mary, which has got 4 units in it, people working on health and lifestyle. So they're working on smoking cessation interventions, weight management interventions, a women's health unit, a global public health unit, and people who work on salt and obesity at kind of the policy level. So there's lots of people for me to newly collaborate with within my centre. And then I'm starting to build quite nice links with the local health system. So Queen Mary's in East London. It's actually a very deprived part of London. And also it is the place where usually migrants to the UK are most likely to live in East London when they first arrive. So we've got very large Somalian populations, Bangladeshi population in East London. So there's quite a lot to do in terms of health inequalities across London, focused on our local population. So working with the NHS Trust, that's actually on the other side of London, Tower Hamlets and Newham local authorities. And then internationally, I have a PhD student who's now, well, a former PhD student who's now in the Ministry of Health in Sierra Leone. So we're working together looking at salt reduction and sugar reduction in Sierra Leone, working in Pakistan with Romena, who you saw earlier. So we've still got plans to do more work on the food environment in slums, and then new collaborations in Brazil. Then Thriving is a large project in the UK that will follow on from Salient, and we will try and expand our current browser extension to look at things like Deliveroo, Uber Eats, so food delivery apps, and then got quite a lot of PhD students currently working on plant-based diets in the UK. I think that what I'd be quite interested to do is try to recreate Salient that I talked about, where we worked with the UK government and the food systems partners to come up with interventions to trial. I'd quite like to do that kind of thing, but overseas with some of the partners that I've now got in Sierra Leone, Pakistan, and Brazil. So those are some of the future plans. That is everything, but very happy to have questions. Thank you.